Let's dive right into this explainer. Today, we're putting on our clinical detective hats to map out the exact step-by-step approach to diagnosing and managing beta thalassemia. We're going to cut through the noise and look at exactly how this condition is identified and treated in the real world. Here is our clinical roadmap for today. 1. Basics of beta thalassemia. 2. Recognizing the clinical features. 3. Step-by-step diagnostic testing. 4. Thalassemia versus iron deficiency. 5. Step-by-step disease management. And 6. The path to a cure. Section 1. Basics of beta thalassemia, setting the baseline. So, beta thalassemia is an inherited disorder of hemoglobin synthesis. Basically, there's a glitch in how globin chains are produced. And these defective genes drastically shift the percentages of hemoglobin types from a normal profile to a severely abnormal state. Think about a normal individual. Hemoglobin A sits comfortably between 90 and 98%, but as we move down to the major form, where a patient inherits 2 defective genes, that normal hemoglobin A just plummets, literally dropping to between 0 and 2%. To compensate, fetal hemoglobin, or HbF, skyrockets up to 95%. Because of this genetic breakdown, the clinical severity varies wildly. We're talking everything from mild, completely asymptomatic forms in the minor trait to moderate anemia in intermedia, all the way down to severe, life-threatening hemolytic anemia in the major form. Section 2. Recognizing the clinical features. The onset. Now, infants with the severe form are actually clinically normal at birth. You might be wondering, why is that? Well, it's because fetal hemoglobin, which is dominant in utero and at birth, doesn't even contain beta chains, so the genetic defect isn't causing any trouble yet. But fast forward to between 3 and 6 months. As that fetal hemoglobin naturally declines and the baby's body tries to switch over to adult hemoglobin, the severe defect is suddenly unmasked. We see a steep decline that triggers progressive anemia, jaundice, hepatosplenomegaly, and a tragic failure to thrive. The stakes here are incredibly high. This severe form causes highly ineffective red blood cell production, known as erythropoiesis, alongside a massively shortened lifespan for the red blood cells that do get made. And the cascade of complications? It's devastating. Severe hemolysis leads to bone expansion. This causes a thinning of the cortex and a very specific hair-on-end appearance of the skull that you'll see on an X-ray. Plus, patients face massive iron overload. This comes partly from the disease itself, but also from the repeated blood transfusions they literally need to survive. This excess iron targets the heart, causing failure, the liver, leading to cirrhosis, the pancreas, triggering diabetes, and the thyroid, resulting in hypothyroidism. And that's not even mentioning the significantly delayed growth and sexual maturity. Section 3. Step-by-step diagnostic testing, the detective work. Okay, so if you're evaluating a patient, you need to rapid fire through these 6 laboratory criteria to build an undeniable case. Step 1. The complete blood picture. You're looking for microcytic hypochromic anemia with a severely low hemoglobin level. We're talking just 2 to 8 grams per deciliter. Step 2. The blood film. Hunt for nucleated red blood cells, target cells, and basophilic stippling. Step 3. Hemoglobin electrophoresis. This is where you look for that massive elevation of fetal hemoglobin, often well over 50%. Step 4 involves checking hemolysis markers, specifically looking for unconjugated hyperbilirubinemia. Step 5 is iron studies, which will reveal high serum iron and ferritin levels. And finally, Step 6, DNA analysis. This definitively detects the exact deletions or mutations in the beta-globin genes. And remember, in beta thalassemia major, both parents will be carriers of the trait. Section 4. Thalassemia versus iron deficiency. Spotting the imposter. Here's the crucial point. When you're looking at a complete blood picture, a mild microcytic anemia could just be the thalassemia trait, the heterozygous, asymptomatic version of the disease. But it could also be an imposter, your run-of-the-mill iron deficiency anemia. So how do we confidently tell the difference between these 2 conditions when the initial blood work looks so remarkably similar? Enter the Menser index. This simple little math trick is our ultimate clinical superpower here. Honestly, it's like an insider medical cheat code. All you do is take the packed cell volume and divide it by the red blood cell count in millions. Burn this number into your memory right now, 13. If the Menser index calculation gives you a number greater than 13, it heavily suggests iron deficiency anemia. But if that number is strictly under 13, it points directly to the beta thalassemia trait. It is an incredibly efficient first-pass tool to guide your clinical thinking. It's fascinating to watch these divergent paths emerge as we build out the broader lab profiles.
while iron deficiency anemia logically shows a decreased red blood cell count and low serum ferritin, thalassemia minor actually presents with an increased red blood cell count and normal or even high serum ferritin. On top of that, in iron deficiency, the red cell distribution width, the RDW, is increased, whereas it stays totally normal in thalassemia minor. When you combine these specific markers with an electrophoresis showing hemoglobin A2 levels jumping above 4%, you've completely locked in your diagnosis for the trait.
Section 5. Step-by-step disease management. The battle plans. Management here is a relentless chain reaction of cause and effect. Step 1, we transfuse. The goal is to administer fresh, filtered, washed-packed red blood cells every 4 to 6 weeks. We have to maintain a hemoglobin level strictly greater than 10 grams per deciliter. But of course, that very solution creates a brand new problem, iron overload. Which brings us to step 2, we absolutely must initiate iron chelation therapy after the patient has received 10 to 15 units of blood. Step 3, we continually monitor the spleen. A splenectomy becomes necessary if the spleen gets enlarged and there's evidence of hypersplenism. Oh, and alongside all of this, the patient is given 1 milligram of folic acid every single day indefinitely, just to support whatever red blood cell production they have left. Let's zoom in on step 2 of that protocol for a second, the iron chelation. Historically, this has been one of the absolute toughest parts of management. Traditionally, it relied on desferrioxamine. We're talking about a cumbersome subcutaneous infusion lasting 8 to 12 hours, 5 to 7 days a week. It's incredibly grueling for the patient and carries nasty side effects like ototoxicity, retinal changes, and bone dysplasia. Thankfully, the medical landscape is shifting. Newer options like deferracrox, which you might know as Exjade, offer an oral alternative. Just think about the immense human impact here. It's vastly improving patient quality of life by swapping out those agonizing daily infusions for a simple pill that actually has fewer side effects, a real game changer. Section 6. The path to a cure, the final frontier. Right now, stem cell transplantation is a definitive curative treatment, and it offers incredible hope for these patients. The data is stunning. It boasts a probability of survival that remarkably exceeds 90%. For a disease that has historically been fatal without relentless, lifelong intervention, hitting a 90% curative survival rate is a monumental medical achievement. But the innovation doesn't stop at transplants. Scientists are now actively utilizing gene therapy, and the approach is twofold. First, researchers are figuring out ways to biologically stimulate the production of fetal hemoglobin, essentially bypassing the defective beta chains entirely. Simultaneously, they're using advanced somatic gene therapy to directly correct the genetic defect right at its root. We've mapped out the genetics, walked through the rigorous step-by-step diagnostic criteria, and reviewed the intricate balance of modern management. But as we wrap up this explainer, I want to leave you with this provocative thought. Are we standing on the precipice of a future where we simply rewrite our DNA to cure previously fatal inherited diseases like thalassemia once and for all? It's a fascinating frontier, and understanding the meticulous steps of diagnosis and management we covered today is exactly how we measure just how far we've come.